dekada nang tayo'y magkakilala. Sabay-sabay tayo yumapak sa landas ng medisina. Sabay nating hinarap ang pagsubok at paghirap, hanggang makamtan natin ang matinyas nating pangarap. Pagsikat ng liwanag sa unang araw ng Mayo, sa taon na tinadhana bilang ating sentenaryo, ay biglang natapos din 5 taon ng pagsisikap, 5 taon ng pagsasama sa oras ng saya't hirap. Tayo ang class ng 98, sa simula napakitang bilas sa loob ng PGH, kay busilak ng utak at puso. Kailan ba'y di nagkulang sa talino at talento? Tayo ang class ng 98. Hanggang ngayon may pakitang bilas. Salamat PGH, mayaman sa utak at puso. Kailan ba'y di nagkulang sa talino at talento? Ilang dekada pang tayo'y magkakasama. Sabay-sabay tayo yumapak sa landas ng pagkakaisa. Sabay nating harapin tagumpay ng ating mithiin, karangalan at galing sa lahat ng ating gawain. Pagsikat ng liwanag sa bawat araw ng taon, pasalamatan natin Diyos na Panginoon, sa alaala't kwento natin ng katuwa at bighati, sa lahat ng pangyayari na naghubog sa atin. Tayo ang class ng 98, sa simula nagpakitang bilas sa loob ng PGH, kay busilak ng utak at puso. Kailan ba'y di nagkulang sa talino at talento? Tayo ang class ng 98. Hanggang ngayon may pakitang bilas. Salamat PGH, mayaman sa utak at puso. Kailan ba'y di nagkulang sa talino at talento?
Welcome to the UP College of Medicine Class of 1998 webinar series. As this year's Silver Jubilarians, our class is hosting most of the webinars this year on Mondays, Wednesdays, and Fridays, unless announced otherwise. Coming from our successful webinars last year, our 2023 theme is still Primary Healthcare in the Era of Universal Healthcare. In this current webinar series, we hope to unlock knowledge and discuss interesting and relevant topics for primary care physicians, including GPs, family and community medicine physicians, occupational and industrial health physicians, as well as other allied medical professionals. Here are some reminders for a smooth webinar experience. Firstly, kindly turn off your microphone and video for the duration of the webinar. Secondly, we encourage you to participate in an interactive discussion at the end of the speaker's presentation. Feel free to type in your questions in the Q&A chat box in Zoom or through the comment section if you are watching on Facebook. They will be addressed in the open forum after the lecture. Let us now begin with a short ecumenical prayer. Almighty Father, we praise and thank you for this day. We come to you asking for blessings and help for our speaker, moderator, and everyone present right now. We pray for your guidance as we unlock knowledge together. We ask that you show us how to conduct our work clearly and with a spirit of joy and enthusiasm. Protect us from the illness of apathy and hopelessness. Instead, keep the fire and love in our hearts as we work together with our colleagues. We ask that you challenge us to reach higher and further to be the best we can be for others. Amen.
Good afternoon to everyone on Zoom and those watching the Facebook and the UP Manila live streams. Before we proceed, let me introduce myself today as your moderator. I am Dr. Catherine Yap Asedillo, Chair of the Philippine Board of Plastic Surgery and part of the clinical faculty of the Division of Plastic Surgery, Department of Surgery, at the Medical City Ateneo School of Medicine and Public Health. I am also a very proud member of this year's Silver Jubilarians, the UPCM class of 1998. And allow me to introduce our esteemed guest speaker, Dr. Deogracias Alberto Reyes, Chief of the Section of Minimal Access Surgery, the Medical City. He is also the Director of the Center for Advanced Skills, Simulation, and Training Innovation at the Medical City, Medical Director at the Sacred Heart Hospital of Malolos, Clinical Associate Professor at the Ateneo School of Medicine and Public Health. Last but not the least, he is also a classmate from the UP College of Medicine class of 1998. Today, he will talk about his area of expertise, mini laparoscopic surgery. Welcome, Dr. Deo Reyes.
Thank you very much, Yan, and good afternoon.
We can start with your presentation.
Yes. All right. So today I'll be talking about mini laparoscopy. The question being, is less better, or is the shorter incision better for our patients? For this particular talk, I have no financial disclosures in relation to our talk today. So at the beginning of the dawn of the golden age of surgery, the larger the incision, the greater the surgeon was the mantra for better exposure and better dissection. The better the dissection, the greater the surgeon. But this has actual implications on the side of the patient in as far as morbidity is concerned. Large incisions tend to cause more pain and more morbidities to our patient, plus the longer time it takes the wound to heal. So in today's surgical environment, minimally invasive surgery, otherwise known as minimal access surgery, has come into the fore and has created a more patient-centered level of surgery, more patient-centered care, if you will, taking into consideration better quality of life and better practice. Our surgeons have taken the task of taking it upon themselves, a more difficult kind of surgery, in place for better quality of recovery and better clinical results for our patients. Thus, minimally invasive surgery or minimal access surgery, a more difficult approach but more patient-centered. So in laparoscopic surgery, standard laparoscopy will involve the use of 5 to 10 millimeter instruments instead of having to make wide open incisions in the abdomen or in the bodies of our patients. These 5 to 10 millimeter instruments are inserted into the body cavity so that surgery may be done through a camera, which is 10 millimeter in size. A further refinement of laparoscopic surgery or standard laparoscopic surgery was for a time single port surgery, wherein multiple ports are put through a single 2 centimeter umbilical incision. So it's a 3-in-1 incision to the umbilicus. And it is illustrated in this picture that I have shown here. Again, the surgeons have taken more of the difficulty and the challenge of performing surgery this way in favor of better recovery, less morbidity, and better clinical results for our patients. Again, the difficulty is undertaken by our surgeons for being more patient-centered. And the next step, as I believe it to be, is mini laparoscopic surgery, or otherwise known as needlescopic surgery. You can see here in picture a 10 millimeter instrument and a 5 millimeter instrument at the middle, which comprises the instruments for standard laparoscopy. Mini laparoscopy is the third instrument here. On the picture labeled B will be a comparison of a 5 millimeter instrument and a mini laparoscopic instrument. As you can see, it is significantly smaller in caliber, therefore thinking that we will be causing less injury and less invasiveness because the incisions to use these instruments will be smaller. So do incisions add up? I offer to you these diagrams wherein in figure 1, you have a major axis of your incision, which is modeled as an ellipse from 0 to L and with the length A. The tension is going to be related to the amount of morbidity, meaning to say pain, chance for infection, scar formation, is going to be directly related to the tension which is found at the center of the incision. So most people who criticize minimally invasive surgery or minimal access surgery is that they can do the same procedures using smaller incisions, and the combined incisions of the trocars will be the same. Meaning to say, if you add up all the incisions, the morbidity, the pain of the incisions will be the same. Now, my presentation will offer evidence that begs to differ with this line of thought. The second diagram basically shows you that the maximal point of tension for a wound, which is L long, is at the center. So the total tension is the area of tension underneath the curve, which is presented by a triangle here, with the angles or the ends of the incision having the least amount of tension and the greatest amount of tension being at the center. So if you will take the total amount of tension for a particular incision, it is going to be the integral or the integration of the surface of the tension within the entire curve, which is this part, from the least tension to the greatest tension at the center of the wound. So if we put several incisions together vis-a-vis one single incision, you can see here that the maximal point of tension in one single incision is much greater than one aspect or one part of that same incision made up of smaller incisions. The maximal point of tension in this incision, as you find here, is just a fraction of that of the maximal tension of a single incision. And if you get the integral or the values underneath the curve of these several multiple incisions, the value is going to be much smaller than that of the single incision with a greater area under the curve. So what does this establish? The relationship is not linear. It is not 1:1, meaning to say, if you increase the incision by so much, the tension only increases by so much. In fact, when you increase the length of the incision by a value A, the tension is equal to T squared. So it is an exponential increase in tension if you do a single length of incision. So the point here in this slide is that smaller incisions do not add up to the length of the tension created by one long incision. So this is just a comparison of the amount of tension that is created by several common procedures, such as appendectomy and colectomy. You will see here that the tension in minimally invasive surgery for appendectomy, for example, is 369.7, which in open surgery is almost 3 times, 986. And the ratio of open to minimally invasive tension is only 2.7. For Nissen's fundoplication, it's a ratio of 4.7, 3.8, and 3.6 in minimally invasive surgery for colectomy. So we are offered here evidence that the tension for wounds in minimally invasive and open surgery is just a fraction of what it is in the open surgery aspect. Now, for hernia repair, the major breakthrough in hernia repair had something to do with pain, tension. Because of this tension, compromised tissue perfusion, and degraded wound healing because of the compromised perfusion. And this was all related to the tension in tissue repair. Now, as the modernization of hernia repair has come into fore, tension-free repair is the modality of choice. With tension-free repair, there is less pain, there is no tension, and therefore there is near physiologic tissue perfusion and no degraded wound healing. Because of these aspects, there are more optimal conditions for physiologic processes in terms of wound healing and tissue infiltration. So this is one example wherein tissue tension after wound closure plays a major role in the morbidity and recovery of patients having to go through procedures. To further the evidence in less incisions or smaller incisions, there is the COS trial and the C-CLOR trial, or the clinical outcomes of surgical therapy, wherein 872 patients having colonic adenocarcinoma were treated with open colectomy or laparoscopically assisted colectomy, and the European Colon Cancer Laparoscopic or Open Resection Study. Now, what did these studies come up with? Number one, factor in response to surgery, meaning to say, the larger the incision, the greater the immunologic response to surgery will be, the greater the inflammation. The response with laparoscopy differs from that with open surgery by virtue of the small incisions that are made. And thirdly, the differential response can be measured and documented, so much so that the impact of this differential can be measured in different groups of our patients, and that this impact is significant and important in terms of recovery and morbidity of our patients. So there is a metabolic and immunologic response to surgery in terms of tension in wound closure. And as I have mentioned earlier, the multiple incisions in laparoscopic surgery do not equate to one longer incision in open surgery. So this tension is now related to immune suppression because of the immunologic response to larger incisions. Also, in open surgery, the exposure of the abdominal cavity to air stimulates bacteria in the intestine to produce lipopolysaccharides and makes the situation more prone or more conducive to intestinal translocation of bacteria. So let's talk about incisions right now. If we talk about incisions, how big does an incision have to be in laparoscopic surgery? A 5 millimeter instrument now will need half the incision or half the circumference of the trocar. If you take a look at it, this is the 5 millimeter port or trocar. If you make the incision into a line, the incision will be half the diameter or half the circumference of that trocar. The incision has to be right to avoid small tight incisions that will require too much force in inserting the trocar, which might result into bowel or vascular injury, injure the skin that will give you compromised cosmesis, and increase the chances for infection. Now, on the other hand, if you make too long an incision, the ports will be loose and they will be insufficient. As you pull in and pull out your instruments through the course of surgery, there might be a need to reposition the trocars as they are pulled out and pulled in along with the instruments. So this is the take-home message of the slide. The proper incision has to be made to avoid inefficiencies in surgery, which is going to be half the circumference of the incision or the trocar. Now, mini laparoscopy has very small instruments, as they are called needlescopic instruments. As you can see here in this picture, the instruments do tend to bend in comparison to standard laparoscopic instruments. But there is a way around it to strengthen the instruments to avoid bending of the instruments. They usually bend at the center, and when you use a port such as this, a rigid port will have the shaft length and will make the shaft of the instrument less likely to bend because of the support provided for by the trocar. Now, in needlescopic or mini laparoscopy, what is encouraged to be used is a longer trocar such as this. Because of the long needlescopic trocar, the division of the forces acting on the instrument will be much smaller. Therefore, the amount of bending or flexing in the instrument will be decreased by using a longer trocar as illustrated in this picture. So the force required with a standard trocar, as I first showed you, because of the flexing of the instruments, will have its high points and low points. It will increase and decrease depending on the amount of flexion that you will encounter in the instruments. Using a long or a Caravaggio trocar, which will protect and strengthen the instrument even more, will show a plateau of force needed during the operation because of the additional support that is provided for by the trocar. Now, how do we use cameras or the scopes in laparoscopic surgery using mini laparoscopic instruments? We do have to switch from a big camera or a big scope to a small scope, from a 10 millimeter to a 3.5 millimeter scope during the conduct of this operation. Now, you can see here a camera adapter that will facilitate the changing of scopes, because in laparoscopic surgery, we wrap our cameras in plastic. Therefore, the camera within the plastic is not sterile. And if you do not have the adapter, you will break the sterility of the plastic when you change scopes. And the adapter is very important so that you are able to maintain the sterility of your camera setup while changing the scopes from a big scope to a smaller scope. So I'd like to offer a short video of the technique of Gustavo Caravaggio, which is a clipless technique in doing laparoscopic cholecystectomy. It is an open umbilical access, a 4-port technique using hook dissection, The cystic artery is not clipped nor ligated. It is merely cauterized. The cystic duct is secured with intracorporeal ligation, and the specimen or the gallbladder is taken out using a bag, using a rendezvous technique with the umbilical cord. So this is a short clip of the technique that I mentioned. So it is an open umbilical technique. And you can see the ports are needle in configuration without any valves. The instruments are a lot smaller than the standard laparoscopic instruments, as you can see. Dissection is done with a hook using electrocautery. And the critical view of safety, as we'd like to call it in surgery, is achieved through a combination of sharp and blunt dissection. So here, the cystic artery having been identified is being controlled by a monopolar cautery, and the cystic duct is being controlled by ligation, intracorporeal ligation of the cystic duct, because there is no needle-scopic sized clip applier. So it takes a little bit more of skill to do mini laparoscopy compared to standard laparoscopy, because clipping of structures is not an option. You have to do intracorporeal ligation and control of structures. So here, the gallbladder is being cut with the use of monopolar cautery, eventually placed. There is the cystic artery being inspected for bleeding. The gallbladder is put into a specimen bag, secured. And the rendezvous technique basically means that one of the operating instruments will be directed directly to the axis of the scope, as you will be seeing here, directed at the scope, and the bag will be exited through the umbilical port or the camera port. So locally, as our learning curve develops, the adopted technique initially compared to the Caravaggio technique is still an open access technique, 4-port technique using hook dissection with peanut dissection to achieve the critical view of safety. The cystic artery is still clipped, but clipped from the umbilical port, which is a larger port, large enough to accommodate the clip appliers. And there is that switch of cameras from a larger camera to a smaller camera that will fit into the mini laparoscopic ports. So the cystic duct is clipped and then looped for security, and the dissection of the gallbladder is done fundus down. The specimen bag is used as a glove of cuff of a glove, and then visually guided to be extracted through the umbilical port as well. So you will see the similarities and the differences between the Caravaggio technique and this adapted technique in this video. So the ports are needle scopic as well, as you can see, very small compared to 5mm instruments. Hook dissection is done. After hook dissection is done, a combination of blunt dissection using a peanut and sharp dissection is utilized to come up with a critical view of safety that will be illustrated here. There's the critical view of safety. Now the switch of the camera is being done. So the umbilical port is used to access the cystic artery with a clip applier to control it. Again, the clip applier is passed through the umbilical port, which is a big port, so that the cystic artery can be clipped. After clipping, it is cut, and the cystic duct shall be secured using ligation. So the instruments are now strong enough to be able to
Oh, we are having some technical difficulties at the moment. Give us a few minutes.
Sorry for that technical glitch. Let me bring up my slides back. Sorry about that. So the adopted technique, as I was saying, is basically an adoption with the considerations for the learning curve of the Caravaggio technique. And this was used using the clip applier, which is passed through the umbilicus, which is a big enough port to accommodate the clip applier, unlike the straightforward Caravaggio technique, which just uses electrocautery for the blood vessels, the cystic artery, in its control. Now, there are assorted procedures that can be done laparoscopically, meaning to say it is not limited by a simple laparoscopic cholecystectomy alone. An IOC can be done using a hybrid technique, meaning to say a combination of a 5 millimeter and a
Yes, sorry to
3.5
interrupt,
millimeter
but the
instrument.
slides are not shared.
Yen,
Yeah, hi. I'm sorry to
they're not
interrupt.
shared.
Uh,
Okay, I'll reshare again.
mm-mm.
Can you see it now?
Yes, we can see it now. Thank you.
You can see it now?
Yes, we can. Thank you.
Okay, thank you. So an intraoperative cholangiogram can be done as well using the mini laparoscopic technique, using a combination of 5 millimeter and 3 millimeter instruments. And the advantage in using mini laparoscopic instruments in an IOC being done in the minimal access technique is that less of the field is covered by your trocars. As you can see here, this is a 5 millimeter instrument, and these are the 3.5 millimeter trocars, which obscure less of the screen compared to a 10 millimeter instrument here. So the smaller the instruments, the better appreciation for your IOC you get, and a better picture of an assessment of the biliary tree that you will be able to afford yourself during the procedure. Additional procedures that can be done using a hybrid technique using mini laparoscopy is a common bile duct exploration using a choledocoscope. Here, a transcystic choledocoscopy is being done to evaluate the presence of a common bile duct stone. So in transillumination, you can see that there is a filling defect in transillumination. And you will see here in the common bile duct, along with the bile flow, is a stone that has migrated into the common bile duct. And with use of a Dormia basket and the choledocoscope, you will be able to extract that, and the stone goes out through the cystic duct using choledocoscopy and mini laparoscopic instruments. Lastly, a patient who had a complex gallbladder, who had a cholecystogastric fistula, is shown in this video. So as you can see, during the dissection, the Hartmann's pouch is closely adherent to the stomach of the patient. Further dissection will reveal that the stone has actually eroded through this hole, this fistula being sutured into the stomach. And after dissecting with mini laparoscopic instruments, suturing of the gastrotomy is done using mini laparoscopic instruments again to close the gastrotomy, and the patient was sent home on the second day of post-operatively. So why was not mini laparoscopic surgery popular from the very beginning? It was basically a limitation of the technology of the instruments that were available. Earlier on, the instruments were fragile and flimsy and provided more complex procedures and more complex instruments that were found to be more expensive and not as robust as the 5mm instruments. But now, since technology has caught up, the fragile and flimsy instruments have become more secure, robust, and less complex. So much so that they can compete in the surgical arena with the standard laparoscopic instruments. So, in closing, we have realized that tissue tension and injury are less with minimally invasive techniques, that there is a physiologic response to surgery that has been documented, which is related to the closure intention of these wounds, that these wounds are not additive in nature, because the smaller wounds have a smaller area of tension compared to one continuous long incision. In laparoscopy, single port laparoscopy compared to multi-port laparoscopy using mini laparoscopic instruments, the ergonomics are preserved, therefore bringing about a more superior level of surgery, simply because you have better ergonomics and you can operate better. Current instrumentation is now robust, and because of this, compared to single port surgery, the learning curve of mini laparoscopy is much more forgiving. And in my view, mini laparoscopy seems to be the natural refinement of standard laparoscopy compared to single port surgery. So simplicity is the seal of truth, and mini laparoscopy is the same, because simplicity, just simply by making things smaller, is the ultimate expression of sophistication. So I'd like to offer some clinical data in a series of 2016, wherein a single surgeon, single institution series of standard and mini laparoscopy was done to a total of 205 patients, 95 open patients, 49 standard laparoscopy, 61 mini laparoscopy patients. The clinical characteristics of the patients are comparable amongst open, standard, and mini lap, except that in mini lap, you have a tendency to get the patients a lot earlier. So right upper quadrant pain is less, and jaundice is less in mini laparoscopy patients. So this is the ALOS, or the average length of stay, wherein the results are obvious. In a matter of in counting by hours of admission, mini laparoscopy is almost half that of standard laparoscopy in terms of qualifying for discharge. The length of operation is slightly longer in mini laparoscopy because you have to adapt to the smaller bites that are being done by the smaller hook. Otherwise, the length of surgery is nearly comparable between the two. The average VAS score In open surgery, the pain is high and tapers off as analgesics are given. In standard laparoscopy, the pain is low and continues to be low at 24 hours post-op. And in mini laparoscopy, it continues to go low. The requirement for analgesia in mini laparoscopy is also documented to be a lot less compared to standard laparoscopy and even more so compared to open surgery. So mini laparoscopy has its advantage in that it has the ability to give you more precise dissection. Instrumentation is more robust, and because of this, the procedures that can be done by mini laparoscopy are comparable. Having discussed the lengths of incisions, the lengths of incisions have a quantifiable difference between open and laparoscopic incisions, and that incisions do not simply add up. Smaller incisions offer advantages both to the inflammatory response, the morbidity, recovery, and return to normal function of our patients. And indeed, size does matter in this case. With that, I'd like to bid everyone good afternoon. I apologize for the technical difficulties and many thanks.
Okay, thank you very much, Dr. Reyes, for that comprehensive overview of laparoscopic surgery and enlightening all of us how it has further evolved into minimal access surgery. No? So as we begin our open forum, we'd like to thank our sponsor again, Karl Storz, for helping make this webinar possible. No? So we have quite a number of questions in our question box. No? Let me start by maybe you can give our audience further information on what currently laparoscopic surgery is being used for in the country.
Yan, the use for laparoscopic surgery is ever expanding. You find surgeons doing more and more cases using laparoscopy nowadays. The standard procedures that are being done using laparoscopy are your cholecystectomies, thyroid, colon surgeries, hysterectomies, adrenalectomies, donor nephrectomies, and the list keeps on growing as we gain more and more experience.
I think it's really good, no, Deo. So, with minimal access, we've even the instruments are becoming smaller, no, and we're honored to have a classmate, no, who is an expert in this field, no. Where are we in terms of like numbers in laparoscopic or minimal access surgery compared to institutions in the first world? I understand it's also institution dependent, no, in the Philippines. But do we have institutions that actually approach the numbers in the first world?
Yan, that's a very good question. It is indeed institutional in nature, but we have institutions which are approaching first world figures. The figures for laparoscopy in some of these institutions initially were the reverse, meaning to say for cholecystectomy, which is the gold standard and standard reference for all laparoscopic procedures, the majority used to be open cholecystectomy still, and minority will be laparoscopic. But nowadays, almost all of these more of these larger institutions in the country actually will have more of the procedures being done laparoscopically. And that's, I would say, approaching more first world figures than ever before.
And I can imagine the impact, no? We're all working towards universal healthcare, di ba? I saw
Yes.
and we know from data and from your own personal data that the length of stay, no, in the hospital is almost half with the use of laparoscopic or minimal access surgery. How many Deo, how many laparoscopic surgeons are there in the country at the moment?
There would be close to 1,200 laparoscopic surgeons in the membership of the society.
And this is all really only from general surgery, no? It might go a little bit higher when you include OBs and
Yes,
urologic surgery.
including the urologists, other specialties who practice laparoscopic surgery. Yes, it will be greater.
That would be greater. And how many training programs do we have in the country for laparoscopic surgery?
Um, that's a complicated question. Basic laparoscopy is now included, Yen, in
Mm,
the curriculum of general surgery. So
right.
if you talk about laparoscopic cholecystectomy and laparoscopic appendectomy, that will be equivalent to the number of training programs in general surgery. Now, in as far as the advanced procedures are concerned, like adrenalectomies, colectomies, thyroid surgery, that will be equivalent now to the number of fellowship programs that we have in the country. For colorectal surgery, for example, that will
Right.
be the number.
Parang field based na subspecialty based. Yeah.
Yes,
We have
yes.
one of these questions there from our chat box. No? So are surgeons doing robotic assisted laparoscopic surgery in the Philippines now? Yes, it's a very good question. No? That's
Yes.
where we are moving towards.
Actually, the field of robotic surgery has gotten to be more exciting right now. The robot is actually very expensive, but has come off of patent fairly recently, as recent as last year. So other companies are producing their own versions of robots, and the price of robotic surgery is going to go down. The short answer to your question is yes. Surgeons in the Philippines are doing robotic surgery. There are institutions like Medical City, UBPGH, who have robots and are doing it now. But you can expect the number to increase as the price of the robots go down.
Okay. We also like discussed no the other day in preparation for this talk. No, you were telling me about you explained it very nicely. Maybe you can tell our audience no about laparoscopic surgery. Well, how it is very useful and indicated actually for certain procedures like hernia. No, this is a
Yes,
really yeah. If you can expound on that.
right. For hernia, we general surgeons are trained essentially to do the anterior approach, wherein and the mesh is going to incite a lot of fibrosis to handle the hernial defect. Now, unfortunately, if we encounter a recurrence of your hernia, a redo herniorrhaphy using the anterior approach is going to be challenging because of all the fibrosis that the mesh has introduced. So in this case, laparoscopic hernia repair, which uses a posterior approach because you go through the abdomen if you do it laparoscopically, will be a very good choice because as you approach the hernial defect, you will not be going through scar tissue, but you will be going through virgin tissue as you dissect. So repair for recurrent hernia is actually better done laparoscopically than an open approach. It is clinically superior if you do it laparoscopically for recurrent hernias.
Yeah, very good. Thank you very much. And I also wanted Deo to bring up like the difference between laparoscopic surgery and robotic surgery. And we discussed that, no? And you had a very nice explanation which I wanted you to share with our audience.
Okay. Um, in essence, laparoscopic surgery was made easier by robotic surgery, simply because in robotic surgery, you do not use straight instruments. If I may demonstrate, in laparoscopic surgery, your instruments are just straight. You go in and out, rotate, left, right, up and down. In robotic surgery, in addition to those movements, you actually have a wrist. You actually have a wrist in robotic surgery, which facilitates a greater degree of movement. Therefore, you are able to dissect with more precision and more intent, especially for the more difficult cases. In addition to that, the risks that are provided for by robotic surgery makes it easier to perform surgery in very closed and confined spaces like the pelvis. So you will see a lot of robotic surgery being done for prostate,
Mm.
for hysterectomy, because of the confined space of the pelvis. And this is where the robotic surgeons really come into fore.
That's right.
Yes.
It's nice, no, that we actually were using technology and we have many tools. Diba? These are just tools. I think I wanted to impress that upon to our audience, no, na parang not one method is better than the other. These are all tools for different indications. Oh, here we have more questions, no. I'd like to thank our
Okay.
audience for all the questions. So is lap surgery usually more expensive than traditional open surgery? Siguro let's talk
Right.
about the most common procedure, call it
Let's talk about cholecystectomy. Right. Um, Unfortunately, the answer to that question is not simple. Um, it all depends on the kind of healthcare system that you have and whether you take into consideration the return to function and lost productivity days concerned. Right. In the local setting, since we do not take into consideration the lost revenue or the lost income because you are not able to return to work, laparoscopic surgery vis-a-vis open surgery is indeed more expensive. But if you take into consideration the earlier return to work and earlier return to function, which offsets the initial cost of the surgery, then laparoscopic surgery turns out to be cheaper for as long as that aspect, return to function, is taken into consideration.
But I believe they that just comparing laparoscopic surgery now to like for example 10 years ago, I think we've actually brought the costs down, no?
Yes, yes,
I'm saying
that's
that.
very much true.
So it's really with the numbers, with the volumes, with more institutions and more surgeons performing it. We've
Yes.
streamlined the processes. We have another question here. Would you consider laparoscopy in younger children, like mini lap already, since they're already using smaller incisions, ports, camera, and equipment?
Well, yes, that's true. In fact, the evolution of the instruments in mini laparoscopy actually was a product of research and development in the field of pediatric laparoscopy. So the answer is yes. In patients who are in the pediatric age group, mini laparoscopy is the way to go.
Correct, that's right. And then because I am, ano na, I'm privileged to know this information. This is really something I wanted to bring up in this webinar. This is your area of expertise. Do you think you can tell us about what you're doing, no, for laparoscopic training in the country and your DOST funded study on
Oh,
stuff? If you're comfortable talking about it, Deo, but I think it's something that's very interesting to our audience, no?
yes, of course, of course. I'll be happy to share. Laparoscopic surgery compared to open surgery is very technology dependent. So the ability to perform procedures greatly depends on the kind of instrumentation that you have and the kind of video systems that you have. So research in this field is very rich, and the research in this field is very readily translatable into clinical practice. So we have a center in Medical City, which is a simulation center that brings the training of simulated surgeries into the OR. So it has been proven that simulated surgeries or performing simulated surgeries actually does improve the surgical performance in the surgical field. So that's one thing that I have gotten myself involved with, simulation training. And secondly, because of the technology required of good laparoscopic surgery, we have gotten CASTI, we have gotten into a DOST funded research project wherein we're developing a blunt dissector for laparoscopy, even for mini laparoscopy. So our funding uh, does cover animal trials and even human trials, which we will be going into at the earlier part of next year. We will be doing a multi-center clinical trial on this blunt dissector that we have developed.
Perfect. Yeah. So Deo, will these instruments be eventually patented?
Oh yes, the criteria of DOST for giving the um, grant is to be able to patent and go to market and hopefully offer the instrument that we develop in the local market. So our local Filipino surgeons will have first crack at the use of this instrument more than the foreign surgeons.
That's right. No, and it would be so nice, no, to have these specialized laparoscopic instruments from the Philippines, no. So we are
Yes.
very proud. Okay, we have one question here. Is numbness normal after a laparoscopy, mini or standard? No, I actually really like that part of your lecture, Deo, when you were talking about inflammation. Diba? The plastic surgeon in me was so happy
Yes.
about the amount of inflammation, the longer incision versus the small ones. And I actually want to add, no, the fibrosis is significant in a full thickness incision, no, versus all these small laparoscopic incisions. Because I think people have to realize that when you injure the skin, you never go back to normal skin architecture because humans, we heal by fibrosis or scarring, no? So that's a big thing, and really it decreases the amount of inflammation post surgery, especially in the first 48 to 72 hours.
Yes.
So this one is talking about numbness, no, in a standard laparoscopy versus mini laparoscopy.
Well, to be honest, I am yet to encounter a patient who has had a persistent numbness post-op in laparoscopy, whether it be standard or mini laparoscopy. What I encounter commonly is a certain degree of numbness after open cholecystectomy or open procedures, simply because subcutaneous nerves are transected during the incision, and that will explain your numbness. But in laparoscopy, I am yet to encounter one, and I do think that the chances of that happening in mini laparoscopy will be much, much less.
How about Deo? How about neuromas? Very rare din
Ah,
siguro because your incisions are so tiny actually.
yes. Neuromas will come into play when we talk about hernia repair. Because in hernia repair, you suture the mesh in place so that it doesn't migrate. There have been reported cases of neuroma post hernia repair. But the
That's
cases of neuroma,
that's because the plane is actually quite superficial.
yes,
Those areas have very high concentrations of nerve fibers.
yes,
Oh,
yes. But if you compare open surgery, open hernia repair versus laparoscopic repair, the incidence of neuroma is a lot less in laparoscopic surgery as well.
uh, certainly. More questions. For
Okay.
cholecystectomy, appendectomy, or colectomy, when would you choose open surgery over a laparoscopic approach?
All right. Um, if you are a properly trained laparoscopic surgeon, I guess the considerations for relative contraindications for laparoscopy will be a frozen abdomen or a frozen pelvis, uh, um, tumors which directly infiltrate into the adjacent tissues. That will be a relative contraindications. But in general, the colorectal surgeons would be able to do it in most cases.
Okay. I think that wraps up, no, our open forum, no? So let's, okay. So once again, Dr. Deo Reyes, we are grateful for your time and expertise and present you with these certificates of appreciation.
Thank you very much, Yen, and thank you to everyone in attendance.
Thank you. So Class 98 would also like to thank those who helped make this webinar possible. No? The University of the Philippines, Manila College of Medicine, the UP Medical Alumni Society, the Postgraduate Institute of Medicine, UP Information Management Service, and of course, our sponsor of this webinar, Karl Storz. We would like to invite our viewers to join the next webinar on the diagnosis and workup of lung cancer in the Philippine setting. No, our expert speaker is Dr. Kenneth Samala, a thoracic oncology fellow at the University of Alberta Cross Cancer Institute in Canada and a consultant at Manila Medical Center, Manila. No, this webinar will be held on Monday, November 20, also at 12 noon. You can use the same Zoom link to register in advance or use the QR code shown here, no, on the slide. And this is for our class activities. Our class is inviting everyone to attend the annual UPMAS Golf Tournament on December 11 at the Ayala Greenfield Golf and Leisure Club. This exciting golf event will include lunch, giveaways, and a raffle, among other highlights. So interested players may register by scanning this QR code or typing bit.ly/UPMASGolf in your browser. And lastly, to receive your attendance certificate, kindly answer the evaluation form, which you can access through this QR code. We will also post the URL in the chat box now. You will be able to receive your attendance certificate only after you've answered the evaluation form. So please ensure that the name you enter in the form is the format, no, the name format that you want to appear in your certificate. So see you next time. See all of you next time as we continue to unlock knowledge for primary care workers and allied medical professionals. Thank you to our audience today, to our speaker, and the UPCM 98 webinar team. No? Thank you very much, everyone.